Welcome to PEM CHATT. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome, everybody, back to the PEM CHATT podcast. I am so excited that you're here today because today marks the 1-year anniversary of our podcast. It has been quite a crazy year, to say the least. This podcast began with the idea of it being something kind of small. We were really providing education to APPs within our own group about how we function in our department, and has become something much bigger than that. I also started with a production team, just a small team of people that were helping me with the editing on the back end and production and all the things that I didn't know anything about with regard to podcasting, and I lost them halfway through the year. So this has been a year of a huge learning curve for me, and we've come a long way as we've moved from purely audio into video podcasting. We've launched a YouTube channel, and it's become much bigger than I originally intended it to be. Now, it's been a year of a lot of times when I look in the mirror and I'm like, what in the world am I doing? Why am I doing this? But by some miracle on those days, they are typically followed by a random email or text from somebody telling me how much they appreciate the podcast. So those moments really go a long way to keep me going and keep me positive. So I really want to say thank you to everyone out there who listens and takes something away from this podcast. So in preparation for today's topic, I just wanted to share with you guys that before I became a nurse practitioner, I worked as a paramedic, an ED nurse, and a labor and delivery nurse. I finished graduate school and was so fortunate to be part of a team that opened up the first OB emergency department in our area. It combined the two things in life that I absolutely love, and that is OB and emergency medicine. That experience later led me back to the emergency department and ultimately into the pediatric emergency department. So I really have those roots to thank for where I am today. If there's one thing that I have learned in working in all these different areas of emergency medicine, it's that we become very skilled at the tasks that we do every day. And when we don't know the answer, we rely on resources like UpToDate, the handy book of pearls you keep in your pocket, or maybe a trusted colleague. But in today's podcast, we're going to discuss OB emergencies that are overlooked and easy to miss. Most importantly, we're going to share some new resources with you about how to navigate these situations like a pro. Now, if you work in pediatric emergency medicine, you might be thinking, why do I need this information? Well, believe it or not, you are absolutely part of our target audience today. What you're going to learn is that you are seeing these patients in the emergency department, but you may not even be aware of it. So stay tuned. We are going to share how to identify these women and what should ring those alarm bells for you when you're seeing these patients in the emergency department. Here today to bring light to this topic is Dayna Jaynstein. She is a PA in Colorado, and Dayna and I know each other because we both serve as stakeholder representatives on an ACOG joint initiative designed to help improve maternal mortality and provide resources, all the resources that I was just talking about. So thank you so much, Dayna, for being here today.
Yeah, thank you for having me, Toni, and congratulations on the 1-year anniversary.
Thank you. Thank you. Very exciting. So before we get started, Dayna, can you share with our audience just a little bit about you?
Yeah, so as you mentioned, I'm in Colorado. I've been in emergency medicine PA for about 16 years. I've also been in PA education for almost 13 years, and I am an assistant director at a PA program. I've had multiple leadership opportunities, one of which is being the past president of the Society of Emergency Medicine PAs, and that's how I got involved in this initiative with you.
So, Dayna, before we jump into the initiative itself, let's talk a little bit about maternal mortality statistics in general. Where do we stand right now here in the U.S.?
I wish that I had happier numbers to discuss, right? But again, that's probably the reason that we worked on this task force and that we're speaking about this today. So pregnancy-related complications result in about almost 1,200 deaths in the United States every year. When we compare these numbers to peer nations, we have one of the worst mortality rates in the whole world. It's important to understand that when we are discussing this topic and these rates, we are talking about an entire postpartum period of a full year. And 60% of these deaths occur within that postpartum period. I think it's also really important that we acknowledge that there are multiple disparities in these numbers. In the United States, Black women have a 2 to 3 times higher mortality rate than white women, and Native women have a 2 to 2.5 times higher mortality rate than white women.
Yeah. I've heard that number even higher, 3 to 4 times for Black and brown women. So,
Yeah.
yeah, incredible. And when I speak on this, I use this graph, I'll put it on the screen here today, that really demonstrates this incredible disparity because everyone else is at the bottom of the graph, and here is this, this population that sticks out like a sore thumb. That's really
Mhm.
sad that
It
we
is.
live in a day and age that that's happening. Well, in response to obviously this problem, ACOG developed this task force. It started in 2019, 2020 timeframe, and then COVID kind of got in the way like it did with everything in the world. But by early 2024, we launched this initiative called Identifying and Managing OB Emergencies in Non-Obstetric Settings. Now, this isn't ACOG's first initiative aimed at reducing maternal mortality, but Dana, tell us what's different about this initiative in particular.
Yeah. So, as you just alluded to, ACOG is just doing exceptional work in this arena. But what makes this initiative a bit different is that ACOG's goal with this one was educating and providing resources to providers who work outside of obstetrics. This initiative is really directed at providing some education and resources to providers working within the emergency and urgent care settings. And then within those settings, the initiative focused even further on specifically trying to tackle cardiovascular emergencies, acute hypertensive emergencies, preeclampsia, and eclampsia.
Yeah. Yeah, I always say, like, people having emergencies do not knock on their OB doctor's door, right?
Right,
Like,
exactly.
they go everywhere else. So, primary care, urgent care, if you're rural, it could be anywhere. And so all of us really have to know about what these emergencies are, how to recognize, how to treat them. So, in general, what is killing pregnant and postpartum women?
Yeah. So, one of the largest concerns that came out of this discussion with the task force was trying to focus in on, a really large topic to provide some education that was focused on hitting the largest issues. And here, cardiovascular issues are by far the most common cause of mortality in pregnant and postpartum women. So, a lot of this work was done at cardiovascular emergencies. We also did do some discussion on hypertensive emergencies and better recognition and treatment of preeclampsia and eclampsia.
And I think when most people think about like maternal deaths, they think about a woman who dies the day she has the baby or in that like immediate postpartum period. But that's really changing. How are we redefining this?
Yeah, again, really great question. And this is one of the largest concerns that came out of the task force was making sure that all providers, especially those within these acute settings, really are working under the same definition of postpartum period. And so we want EM providers to really think about these complications much longer than we usually do. Those of us in these settings usually think about postpartum risk for about 6 weeks, right? Because that's when a lot of these events happen. But these women are still at a significant elevated risk for a full year. And so we need to consider that additional period of time.
Yeah. Do you remember when you go back to think about when you were in school, like what you learned the postpartum period was?
Yeah, I really do think it was like, hey, within 6 weeks, be concerned. I personally don't recall really learning that it was a full 12 months.
Yeah, I definitely didn't. And then
Yeah,
when I had a baby, like you go to the doctor at 6 weeks and they're like, you're good, right? Like,
right.
so
Yeah. And then so you assume that it's over and you should just be moving on.
Yeah, yeah. But when you look at the physiology of pregnancy, which is really cool, we could do a whole podcast on that. You have heart remodeling and all these changes, physiologic changes that take a full year to come back to normal and even longer in some women. So you have to remember that this isn't just you pop a baby out and, have some fluid shifts. Like this is really a body that's changed. And it takes a long time to get that back to her pre-pregnancy status.
Yeah, absolutely.
Now, as you can imagine, many of these late postpartum women don't look pregnant and they may not tell you that they had a baby. So, how do we identify these women that are postpartum and maybe we're not aware?
Exactly. And that was actually one of the largest goals that this initiative came up with is that we really want to change the question that the entire healthcare team is asking. The question really needs to be, are you currently pregnant or have you been pregnant within the last 12 months? We want to not only make sure that healthcare providers are asking that question correctly, but we want to also present this information to women themselves and help educate them that their postpartum period is also 12 months. So we did create some posters and things that we're hoping that departments may be able to hang up in things like hallways and restrooms to kind of flag women to say, like, hey, if you've been pregnant within the last 12 months, please make sure your provider knows that.
Working in pediatrics, I'm not asking every single patient if they've been pregnant. I'm not going to ask a 9-year-old girl, are you pregnant now or have you been pregnant last year? But certainly when I'm talking to early adolescents, usually around 12, 13, 14, I do routinely ask something like, have you ever been pregnant? Especially among those that have medical complaints,
Mhm.
because knowing about this history is part of building your differential, right? You're not going to
Yeah.
consider some of these things. And I feel like knowing that you need to collect that history kind of triggers you to open up that differential to consider some more concerning things. And there are basically two responses in the PEDS when you ask this question. It's either like shock and horror, like, oh my God, did she just ask me if I've ever had a baby? Or on the flip side, they're like, oh yeah, I have two babies. I had a baby 3 months ago. And I'm like, oh, okay. Like, you don't even look old enough to have a baby.
Yeah.
um, but it's been shocking how many people do say yes. And I'm like, a few years ago, probably wouldn't have asked that questions.
Yeah. So good on you for incorporating that question. I bet that you've obtained some really important information and have probably actually picked up on things that might have otherwise really been missed.
So let's get back to the ACOG initiative. What exactly are the resources that they're giving us that we can access?
Yeah. So on majority of these resources are available on ACOG's website. And there on the website, you're going to find obviously access to all of ACOG's care guidelines, right? It's a very amazing resource for us that we should probably be using more. But specific to this task force, you're going to find some algorithms, and they're kind of created to separate emergency departments from urgent care. And then within those care settings, you will find a specific algorithm that is allocated to evaluation of cardiovascular disease in this population. You'll find one for acute hypertension, and then you'll find additional ones for preeclampsia and eclampsia.
Yeah. And I'll put that QR code here and there'll be a link in the show notes for anybody that's not watching on YouTube.
Great.
So let's talk more about cardiovascular disease related to pregnancy and postpartum. Why are these women more at risk for cardiovascular disease and what are we looking for?
Yeah. So, first, I think it's really important that we acknowledge that cardiovascular disease is actually the leading cause of maternal death in the United States. So, these are the women where we really can make the biggest difference here. If we think back to kind of our early physiologic learning days that we were going through, these women during pregnancy can increase blood volume by 40 to 50%, which also increases cardiac output by up to 50%. So these factors lead to significant increased cardiac stress. And it also means that these patients in the pregnancy and postpartum period are considered and to be in prothrombic states, right? So we also want to have high consideration for them being hypercoagulable. To kind of frame this, patients who are pregnant or in that postpartum period have a 3 to 4 times greater risk for an MI than a woman of comparable age who is not pregnant.
Mhm. And I feel like the and we're gonna talk about this more, but, like, the other sneaky thing is, like, they're young and healthy, right?
Mhm.
Like, this is not a 70-year-old that comes in and necessarily looks ashen and you're like, "Oh, I know what your problem is." Like, this
Right.
patient is young, they're gonna compensate until they don't. And so you really have to get out of that, like, "She looks great, I don't need to worry" kinda situation.
Right. And the other thing that's concerning here is that some of the complaints these women have, things like fatigue, dyspnea with exertion, orthopnea, peripheral edema, these are things that can be symptoms of pregnancy itself. And so when these women have these complaints, we just seem to be much more, down the pathway of being like, yeah, it's probably because you're pregnant,
Mhm.
than really diving into these complaints and having a stronger consideration that, hey, these symptoms might actually be more concerning than a patient just pregnant.
Yeah, I gotta tell you, over the years teaching OB to people, this was one of the most difficult areas to help people with, and I really wanted a graph, a grid, something to tell me like when do I need to be more concerned? And that's really what's on this algorithm. Tell us how we can use this algorithm to sort of differentiate these patients.
Yeah. So, as you'll see kind of at the top of the algorithm, it's that initial question, right? Again, we really, really want to stress that we're asking, are you currently pregnant or have you been pregnant within the last 12 months? And then the goal of this is to kind of help providers have that ding moment of being like, okay, wait, I know that you're now at an elevated risk and that the symptoms that you're complaining of can actually be more red flag symptoms of a cardiovascular complaint than just that, again, oh, you're pregnant, you probably just don't feel well.
Hmm.
And so those are the kind of the highlights of the top of the logarithm, making sure that we're just kind of keeping these potential complications at the forefront. And then from there, you'll kind of move into some of the more concerning cardiovascular emergencies that we need to consider in this population and kind of helping evaluate like, hey, did you consider a cardiomyopathy in this situation? And to evaluate for those kind of emergent things. We further wanted providers to kind of be like, hey, if something's going on here, not only should we be working with cardiology, but we do need to get our OBGYN colleagues involved in these patients also. I think we sometimes forget to do that. And then lastly, the algorithm is going to give additional information on medical treatment. But what we really wanted to stress was that no life saving medication should be withheld from any pregnant or breastfeeding patient.
Hmm. Yeah, and in diagnostics too, I've so many times I've seen
Mhm.
my friends like not want to do a chest X-ray, and I'm
Yeah.
like, do the chest X-ray.
Do the chest X-ray, get the CT because if they
Yes.
have a saddle PE, you're in trouble. Yeah,
Yes.
absolutely.
Yeah, yeah.
Yeah,
Forget she's pregnant. Like let's take care of her and make sure she doesn't have this horrible thing wrong with her.
yeah,
Yeah.
absolutely agree.
Yeah. So, what advice would you have for a pediatric provider who is either seeing a young lady who presents postpartum with these symptoms, or perhaps you're seeing their baby and you notice that maybe she's exhibiting some cardiovascular symptoms?
Yeah, I think this is probably a patient that all of us can see fairly commonly.
Hmm.
And I just want us to, again, just to have that ding moment of like, ding, remember that this woman is at increased cardiovascular risk and that we should take the complaint seriously. The second thing is that if you are seeing the baby itself, you're taking care of the patient, don't miss out on an opportunity to also just have a check-in with mom, right? Say, how are you feeling? How are you doing with things? Um, Make sure that she also is aware of her risk. Just say, like, yeah, I know that you're maybe breastfeeding and getting up at night, not sleeping well, and these kinds of things, but you are at additional increased complication risks even during this early period. Make sure that if some of these signs and symptoms come up that you do also seek care for yourself.
Yeah, yeah, I love that. And I think, working in peds EM, we very frequently are considering cardiovascular things like arrhythmia, heart failure,
Mhm.
hypertrophic cardiomyopathy is always kind of on the back of our mind. But these other diagnoses that you see on this list, we kind of like think, oh, those are adult problems. And we don't worry as much as them for them happening in children because they're very rare. However, we have to remember that this population is different. They've recently experienced a pregnancy. They are at increased risk for cardiovascular system complications. They're physiologically altered. And the main take home point here today is to broaden your differential in this group. Consider these more serious things. Consider getting that troponin, a BNP, an echo, talking to cardiology, doing those things that maybe, you wouldn't have thought of before, but now we know this is a red flag because of the population she's in. And remember that diagnoses like hypertrophic cardiomyopathy in children, they're really sneaky and they can present really vague. They are frequently missed. So we got to stay alert for these types of diagnoses. And these are the same, especially if you're seeing a young lady who is presenting for the same complaint over and over again. Cardiomyopathy was once touted as the most missed postpartum diagnosis in OB. And it's because they keep coming with complaints and people write them off. So you have to have a high level of suspicion. And on the flip side, like Dayna so nicely mentioned, in pediatrics, we are often not just taking care of that patient in front of us, right? We are taking care of a family. So if you hear a mom struggling or you check in with her and she's having these symptoms, we have to advocate for her too, right? She's got to be here to take care of her baby. So whether that's in your ER or you facilitate her getting seen in another ER, we're always thinking of this as a family affair and not just one patient. Okay. So the other two algorithms that you mentioned are really focused on hypertension management, preeclampsia, and eclampsia. It's essential when we talk about these, and I want to put this out, in bold letters before we get going here, that this is a little different population we're talking about, and people get confused. But we're really targeting 20 weeks pregnant through the 6-week postpartum period when we talk about these upcoming algorithms. So let's talk about what high blood pressure in pregnancy is.
Yeah, another great question. And I think another one where providers kind of all have different answers for this. And so we wanted to kind of put it out there and so that we're hopefully all working off the same groundwork here. So for blood pressure or hypertension in pregnancy, that's defined as a systolic pressure greater than 140 or a diastolic greater than 90 in a pregnant woman with no prior history of hypertension. We do consider a systolic pressure over 160 or a diastolic over 110 then as severe hypertension.
Yeah, and I always say people, it doesn't have to be both, right? It can be one or the other. So 162 over 90 is still considered a severe range blood pressure. And if you have worked in OB, you know that if OB uses the term severe, that means we need to do something about it. So severe range blood pressure. And when you talk to your OB colleagues, being able to say, I have somebody here with severe range blood pressures, those are blood pressures, the 160 over 110, is very helpful to ring some bells from them. I must say, I worked in an OB/ED for a long time, and one of my biggest frustrations was seeing patients who had been to an outside ER, and then they show up to the OB/ED, and I see these prior visits, and nobody recognized this hypertension. And then I transferred to the ER, and I realized that every single human being in the ER has high blood pressure, and usually much higher than the numbers we're talking about right here. And in general, for most conditions, we're doing nothing about it. Like, right, we ignore these blood pressures in most people. And on top of that, people are not recognizing people who are pregnant or postpartum. Like, that's not always flagged in someone's chart. So really, this is like a recipe for missing these patients, right? Like I feel like I see it happen all the time around me if I'm in the regular ER. It's even happened to me in the children's ER. We're just not acutely aware. Have you made any changes to your practice, like how to avoid missing this group of people?
Yeah, and it's great that you brought this topic up because like I absolutely agree, right? We've fallen into this pattern in the emergency department and we can talk about the semantics of that at a different time, but um of being like, you know, if the patient is asymptomatic, we tend to not even care about their blood pressure anymore, right?
Mhm.
We're like, yeah, it's high, but they have no symptoms. Follow it up
Go see your
outpatient at
PCP.
some point, right? Like,
Yeah.
we've kind of just been like, they don't have a headache, they don't have chest pain, they can go. And it strongly needs to be reframed in light of pregnancy and in postpartum patients. Is that even an asymptomatic patient who is currently pregnant or within that 6 weeks of postpartum with an elevated blood pressure needs to have their blood pressure addressed. And so, at minimum, in the emergency department, these patients need to have some type of plan moving forward with their OBGYN to initiate treatment here. We don't wait for these patients to come in with the headache and the chest pain and some type of symptom.
Yeah, it's never benign in pregnancy and postpartum.
Correct.
In communicating with your team, I feel like the most important thing I ever did working in the ER I did was like teaching people in triage. Like, if you meet a pregnant woman and she has this blood pressure, I need to know immediately. Don't put her back in the waiting room for 3 hours. I need to know that so that we can act on that immediately. And so when I speak about this, I pass out little buttons to people just so they can wear them with the numbers on their badge and like just create conversation with your team. And I think that's the most important take home here is communication so that everybody from the tech to the nurse to the providers knows it's a hypertensive emergency at 160 over 110.
Yeah.
Okay. So the algorithm is available to help us navigate these patients. Let's kind of use a scenario here. Let's say I'm in the ER and I'm seeing a 15-year-old girl. Her chief complaint is headache. She doesn't look pregnant because no adolescent ever does. I asked my patient because I know about this, are you pregnant now or have you been pregnant in the last year? And she says, yeah, actually, I had a baby a month ago. So walk me through your approach to this visit and how you're going to use the algorithm with this patient.
Yeah. So this patient is something we could see all the time, right? And first off, I have to congratulate you on asking, or have you been pregnant in the last year? Because that classic question of, do you think you're pregnant would elicit a no. And that could be very important care changing information, right? We need to know this. So, first off, asking the correct question is the way to go. Second, now that we know that we have a patient who is in their postpartum period, and we know that this is an increased risk, we have to have a heightened level of concern here. So she is complaining of a headache, right? So we want to keep that in the back of our minds as well. But the first thing I'd want to know, like, is she hypertensive? And that's going to kind of help us start to try to differentiate what's going on here. So as we had mentioned earlier in this discussion, right, is we need to keep the possibility for preeclampsia on our differentials much more, and we need to be more aggressive in our evaluation of hypertension in this population. So, not only here would our differential potentially include intracranial issues and stroke and things, but we do want to consider preeclampsia. So, therefore, we would kind of pull one of these algorithms and take a look at it, make sure that we're doing the correct workup here. So, we want to monitor blood pressure every 15 minutes in this population. We want to get a CBC, a basic metabolic panel. We do want to take a look at liver tests. And then a urine protein creatinine ratio is really going to be helpful in us figuring out what's going on. Obviously, get neuroimaging and other things as deemed appropriate in your evaluation. But once you've kind of narrowed in and you're like, hey, we're in that preeclampsia possibility, we really want to make sure that we get OB involved and have some input from there on what they recommend that we're doing. And if we're not thinking of preeclampsia and we're thinking more between that hypertension, should this 15-year-old be treated for this blood pressure today? And so, again, I think our OB colleagues are really going to help us out with that. So, the algorithm is going to kind of help prompt us along the way to make sure we did the correct workup, considered the right things, consulted the correct people. And then, lastly, there's going to be some information that's really detailed on the management here. We get a lot of input from providers of being like, okay, I get the diagnosis. It's the medication and the management that I really need focused content on. And
Right.
the algorithms are going to provide that for us. So you're going to have medications specific to preeclampsia, specific to acute hypertension, and the dosing associated with those to really just have a go-to reference.
Yeah. I find that like ER people in general are afraid to give mag too. Has that been your experience?
Absolutely. Yes.
I mean, we're just like scared of things we don't do,
Yes.
And having worked in OB, I'm like, yeah, give her mag. Like,
You're
what's the big
mad.
deal? But like I've done it thousands of times, right? So
Yes.
yeah, you have to remember, like, if this is not something you're doing every day, it's not very intuitive. And
Right.
that's what this algorithm really will solve for you. So put this in your back pocket, put a thumbnail on your phone because it walks you through the dosing, how to give it, the timing of the dose, and how to manage this patient. It's literally step by step. It's super duper easy, made for people who don't do OB every single day, right?
Exactly. Exactly.
And that's what we needed. Like, this is a team sport.
Yeah.
We have to get away from like all separating ourselves and come back to being a community, right? Like,
Yeah.
we need to be kind to one another, and we need to support each other. And that's what this is meant to do, is to give us the knowledge that we need to feel comfortable taking care of these patients. So
Yeah.
so go to that algorithm. So there's a second algorithm that's specifically for eclampsia.
Mhm.
For anybody who may not know out there, what's the difference between a preeclampsia and an eclampsia?
Seizure,
Yeah.
actually. Yeah.
So just you're basically the same symptoms. You're hypertensive, you got proteinuria, the other potential lab changes, and now you've had a seizure. So let's change our patient scenario and say still have a 15-year-old come in, except she's coming in via EMS and she had a seizure at home. She has no seizure history. She's still postictal, and you don't really know anything else about her. Run me through how you might approach this visit and then use the eclampsia algorithm.
Yeah. So, we all work in emergent settings, right? And nothing gets more chaos going in the emergency department than an actively seizing patient, right?
Mhm.
Like everyone's just seizing, and then everybody kind of forgets everything to do, with the exception of like get a glucose level, right?
Right.
And so I think this is really important for us to kind of talk about this situation. Is one, again, in this care setting, especially as a 15-year-old presenting with potentially new onset seizure, right? No diagnosis of it, is that we have to consider that this could be eclampsia here. And I think that that's a differential that we kind of often forget to include.
Mhm.
And so that's number one, is just being like, hey, I have a patient in front of me who is technically of childbearing age. Could this be eclampsia? and trying to get additional information if it's possible. Has this patient recently been pregnant or delivered? I think the other thing, and you had just kind of alluded to this, that we heard from a lot of providers is again their discomfort with some of these medications and the mag sulfate dosing and the loading dose and the maintenance dose and then what do you do if a patient is having persistent seizures or recurrent seizures? And so this algorithm is actually predominantly more just focused on the medications in order to help us initiate these treatments much earlier in a fairly chaotic situation of a seizing patient who is probably potentially eclamptic.
Yeah. I love this algorithm, even in OB, even for OB people, because it's just everything is right there at your fingertips. And what are you going to do? Like, there's always those. I don't know if you're like the black cloud at work or the white cloud at work, but like, there's always that provider out there that like all bad things happen to you. Well, you need to put this in your pocket.
Yes, agreed.
Because
Yeah.
it runs through your benzodiazepines, your phosphene, all the things that you might need for those refractory seizures that don't want to stop. And then, considering your brain imaging and how to get everybody on board. But most importantly, how to start your mag and how to dose it. I think
Yeah,
that's tough for people.
agreed. And again, it's laughable why emergency providers are so uncomfortable with fairly benign medication, but we are. But it gives it to you. And then I just also kind of want to stress, just for viewers and listeners to know, is that mag sulfate dosing is not weight based, and so therefore these recommendations would be the same for the teen population.
Right, right. And you're going to see I've worked in OB in couple different places in the country. And so I know it's very regional. And so you're going to hear different numbers from different people. And when you look at the algorithm, there's a range, but just for the ease of your mind, if someone is seizing, load them with 6 and then run it at 2. If they are not seizing and they are preeclamptic, load them with 4, run it at 2. That's just kind of a nice round numbers, easy numbers that you can remember. You might hear other things from specific OB providers about how they want it. And you do have to consider renal complications, or if the patient is 60 pounds, they may be a little bit more sensitive and need a little less of a load dose or a little less at the hourly rate. But those are just kind of nice, easy numbers to put in your pocket and what we most commonly use in OB. So a great algorithm. I can't say enough wonderful things about it.
Yeah,
All right.
agreed. Agreed.
So, in closing, just to kind of wrap up, I just wanted to stress that it's important to understand that most pregnancy related maternal deaths are entirely preventable, like Dayna talked about. That being said, OB providers cannot reduce the maternal mortality rate in this country by themselves. This is going to require a team effort, and all of us, whether you work in primary care, urgent care, community based ED, anywhere. So we all need to be aware of what pregnant and postpartum women are at risk for, how to identify them very early in that encounter so that we can consider additional things on our differentials. And today we discussed how pregnant and postpartum women are at increased risk for cardiovascular disease, ACS, cardiomyopathy, hypertensive emergency stroke, just to name a few. The first step here is awareness, right? We have responsibility in each of us to consider these things on our differential diagnosis and then utilize these new resources and advocate for our patient, whether it's the adolescent that you're caring for or whether it's the parent of the baby that you're caring for in the ED. But I'm going to ask you for one more thing, and that is to share this information, right? So tell your team about this. Print the algorithm, hang it at work. I work at a children's ER, and you better believe this acute hypertension algorithm is hanging on the wall in the center of the ER. Educate your staff to ask about pregnancy and postpartum status in the patients at triage. Teach them what constitutes a hypertensive emergency. I've had teammates in the children's ER call me at home when they had a patient with hypertension and ask what to do. And we have an OBED. So, educate people and they really become attuned to this. We're all capable of doing this. Together, we can really make a difference here and prevent these tragedies and help improve survival for these moms. Be the one who changes an outcome. Be an advocate, be a leader, be a voice. Now, before we close, Dayna, if there was one thing that you wanted our listeners to know or remember from today's show, what would it be?
Yeah. Again, really great synopsis in wrapping this up. And I just can't speak high enough about the importance of the subject. We need to do better for these women. And it's here and it's presented to you in a very usable, digestible manner. So go get those algorithms, print them, bookmark them, take a screenshot, do whatever it is that works for you, but have them available. And as you had mentioned, share them. And together, I think we can hopefully really, really make some positive strides in this area.
Thank you so much for being here.
I appreciate you. Thank you for having me.
All right. Well, thank you guys for being here with me today for this really special episode, the 1-year anniversary of the PEM CHATT podcast. And this episode about maternal mortality and how we as individual providers, no matter where you work in medicine, can really make a difference for this at-risk group of women. Now, join us next month when we'll be back with our 2 clinical pharmacists, Maggie and Morgan, to finish up our 2-part series about pediatric medications. And in the second podcast, we're going to talk about all the other medications we use in the ER. So lots of little tips and tricks so that you can do a great job taking care of all your pediatric patients. I look forward to seeing you next month. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.